move on to the next speaker. The next speaker is Dr. Daniel Chong. He is a senior consultant and a heart rhythm cardiologist at National Heart Centre Singapore. And he will share with us on the update on stroke prevention of atrial fibrillation. Daniel, over to you.
Thanks, Chee Kiong. All right, so the topic today that I've been given is essentially stroke prevention of atrial fibrillation, what's new? And I think that over the past 10 to 20 years, I think there are three major aspects of stroke prevention in atrial fibrillation that are new, or I will say that they have made major changes. One would be the widespread adoption of a clinical risk scoring system to sort of predict who would benefit from anticoagulation. So the CHATS-2 scoring system that was first published in the guidelines from 2001 by the ACC, AHA, and ESC, as well as the CHATS-VAS score that subsequently was published by the ESC in 2010. Of course, there were publications before them, but the guidelines of 2001 and 2010 are the ones that sort of made these scoring systems really widespread in use. The second major advance has been actually the use of NOACs, non-vitamin K antagonists, oral anticoagulants. So these are medications such as the Vigatran, rivaroxaban, apixaban, and edoxaban that have been approved in various countries from 2010 to 2015, and also available, with the exception of edoxaban, in Singapore. And then finally, I think from 2014 onwards, we had the use of mechanical left atrial appendage occlusion device publications, which showed that in certain cases, certain situations, this can be fairly equivalent to warfarin. All right. However, what about in the recent 1 to 5 years? In the recent 1 to 5 years, I think we have learned a lot more about the all these risk factors. We have learned that stroke risk factors in AF patients are not necessarily straightforward. This is an interesting paper from the European Heart Journal in 2019, just last year. And in this paper, a CHATS-VAS score of 2 and above, then patients should be anticoagulated. And they studied and they saw that if somebody had heart failure, so a score of 1, actually, if you want to anticoagulate this group of patients, the age at which they should be anticoagulated should be the age of 35 instead of the age of 65. And if a patient had diabetes or hypertension, then the age should be 50, and if it's vascular disease, 55. So it's not exactly straightforward as to what age thresholds we should use. Although we know that the older the age, the more likely that somebody is going to get a stroke and in atrial fibrillation, therefore the more likely we want to anticoagulate. And over the past 1 to 5 years, there's also been a proliferation of risk factor scoring systems. So we know that in 1978, we knew about the increased risk of stroke in AF patients. And in the 1990s, we realized that warfarin was associated with reduced risk of stroke. But since the CHATS-VAS score of 2010, there have been a multitude of other scores, the ATRIA score, the R2 CHATS-2 score, R2, 2 points for renal disease, CHATS-VAS score, omitting the gender, S stands for gender, the modified CHATS-VAS score, which used an age cutoff of 50 to 74 as 1 point, the CHATS-VAS R score, where R stands for race, African Americans having 1 additional point, and even the CHATS-2 VAC score, where the K stands for kidney disease, and K, if the GFR is less than 60 mils per minute, then that's an additional point. So there have been multiple scoring systems, and of course the latest is the Garfield AF registry score, which is based on a computer machine-based learning model. This is just an example of what we can actually use nowadays. So this is available on the web. You can go to this website and you can just type in your patient's particulars like age, weight, pulse, blood pressure, and whether he or she has dementia, diabetes, and so on and so forth. And this AF registry computer machine learning model will help to predict the patient's mortality, ischemic stroke and systemic embolism, and even major bleeding risk. However, besides all these clinical risk factors, in the recent years also there have been widespread research into other stroke risk factors that have not been used in some of these clinical algorithms. So for example, this is one of those publications. It studied those patients who had a higher atrial fibrillation burden, meaning that somebody who has non-paroxysmal, so this is NPAP, non-paroxysmal AF. That means that their AF episodes lasted more than 7 days, for example, versus those with paroxysmal AF. That means the AF episode would start and terminate within 7 days. And it showed that, you know, when adjusted, the risk of actually stroke is higher, stroke or systemic embolism is higher in somebody with a higher AF burden, for example. Okay, and not only that, I think in recent years also there have been widespread interest into the left atrial appendage. Studies have been published that show that left atrial appendage function, for example, peak left atrial appendage flow velocity, for example, or even mean contraction velocity, have been associated with stroke risk. The morphology, whether the appendage was cauliflower in shape versus whether it's a chicken wing in shape, and studies have shown that cauliflower shape or multiple trabeculations in the left atrial appendage are associated with a higher risk of stroke compared to a very simple chicken wing shaped left atrial appendage. Even the orifice area, the larger the orifice area, the higher the risk of stroke. And even the presence of fibrosis in the left atrial appendage would have a higher risk of stroke as well. And not only the left atrial appendage fibrosis, but on MRI, if we are able to identify the amount of fibrosis in the left atrium, and this is difficult, but if we are able to do it, it seems that it is also predictive of stroke risk. And not surprisingly, people having looked at fibrosis and abnormalities in the atrium went on to look at ECG features that would predict fibrosis and therefore subsequently stroke risk in AF patients. And this is one such study published only last year in Circulation. So in this particular study, the authors looked at multiple P-wave indices, and one of them, the abnormal P-wave axis, defined as a P-wave on the ECG, 12-lead ECG, that is outside of between 0 to 75 degrees. So when the P-wave axis is outside of this gray zone, it seems that this is predictive of increased stroke risk in AF patients. So in this particular paper, you can see that they added this P-wave axis abnormality with 2 scores into the Chatz-VAS score that we are familiar with. And by adding it into 2 separate cohorts, the ERIC cohort and the MESA cohort, the C statistic, that means that how accurately it's able to predict stroke risk, actually increased when you added this P-wave abnormality, this P-wave abnormal axis, from 0.6 to 0.67 and 0.68 to 0.75 in these 2 cohorts respectively, with a significant net reclassification improvement. Okay, that is statistically significant. So it seems that there are many things. Even troponin I as well as NT-proBNP have been used and have been shown in this particular risk score, the ABC stroke risk score, to be predictive of stroke risk in AF patients, and even better, being a bit better than the Chatz-VAS score. And you can see that the higher the score on this ABC scoring system, the more likely someone is able to get a stroke. So therefore, in the recent 1 to 5 years, I think the risk factors that we look at to see whether somebody is at higher risk of stroke has actually increased. We have actually gotten more and more risk scores. We have actually identified that the burden of AF is important. We have also identified that different left atrium and left atrial characteristics, including size, function, shape, fibrosis, all can increase the risk of somebody getting a stroke. Biomarkers as well, such as BNP and troponins, and even certain electrical ECG indices, such as the abnormal P-wave axis, seems to increase, seems to have some predictive value. So therefore, it's not surprising that in the latest guidelines from ESC of 2020, we can see not only the usual common clinical risk factors, but they have also indicated that there are many other clinical risk factors that can help to indicate whether somebody is at higher risk of getting a stroke from his or her atrial fibrillation. So such as renal function, sleep apnea, hypertrophic cardiomyopathy, amyloidosis, for example, as well as imaging markers on echocardiography, such as what I mentioned earlier, including aortic plaques and even a small vessel disease on cerebral imaging. And for biomarkers, a whole long list, troponins, BNP, and so on and so forth over here. All right, but despite all those, it is still highly recommended at this point in time that in clinical practice, it is difficult to do all those fancy left atrial appendage function parameters. It's very difficult to measure the degree of left atrial fibrosis on MRI. And so practically speaking, the recommendation is still to fall back on the tried and tested CHADS-VAS score. So the CHADS-VAS score uses all these factors. CHADS stands for, each one stands for something. C for heart failure, congestive heart failure. H for hypertension. The first A, which is 2 points, stands for age 75 and older. D for diabetes. S for stroke, previous TIA or thromboembolism. V for vascular disease, meaning an angiographically significant coronary artery disease, prior myocardial infarction, peripheral arterial disease, or aortic plaque. That's 1 point. And then if the age is a bit younger, 65 to 74, 1 point. And sex category, if female, 1 point, a total score of 9. And so when do we anticoagulate? I think the guideline still remains quite clear. For those who have atrial fibrillation and eligible for oral anticoagulant, that means that they are not actively bleeding, for instance. Then those with a prosthetic mechanical heart valves or moderate to severe mitral stenosis, they would not be suitable for NOAC, but they would need anticoagulation. So we will anticoagulate them with warfarin. But for everybody else, which is the majority, then we are supposed to identify the low-risk patients. The really low risk are those with a CHADS-VAS score of 0 in males and 1 in females. And in this very low-risk cohort, no antithrombotics are recommended. That means not even antiplatelets, not aspirin, not clopidogrel. If, however, the patient is not in the low-risk group, then we should anticoagulate with NOACs being recommended, and if not NOAC, then warfarin. The ESC guidelines also recommend calculating the Hess-Blood score and assessing which are the modifiable bleeding risk factors that we can try to intervene so as to reduce the bleeding risk. So these are some of the bleeding risk factors, such as uncontrolled hypertension, abnormal renal and hepatic function, prior stroke, bleeding history, labile INR, elderly in age, drugs such as concomitant use of antiplatelets or NSAIDs, as well as excessive alcohol drinking. And some of these are modifiable, such as excessive alcohol drinking or concomitant use of antiplatelets, for example. So we should all be mindful of this and try to modify them accordingly. Of course, there are some non-modifiable and there are other modifiable risk factors, which I will not go into, but suffice to say, try to identify them and try to make sure that they are minimized as far as possible in our patients. All right, I would also like to mention that East Asians in particular are at increased stroke risk. So in the past 10 years or so, from very large trials such as the RELY, Aristotle, and other trials, we have seen that you can see that Asians are at high risk of stroke or systemic embolism. For example, you can see Asians here versus non-Asians. Hazard ratio is much higher. Even in the Aristotle trial, East Asians versus the rest of the world. So you can see that Asians, especially East Asians, are at higher risk of stroke. And this is also borne out in this large population-based study of CHADS-VAS score. You can see that amongst the Hong Kong and Taiwan cohort, compared to the Swedish cohort, for every single CHADS-VAS score, the Taiwanese and the Hong Kong cohort have a significantly higher risk of stroke compared to the Swedish cohort. And this is all throughout all the CHADS-VAS levels. And therefore, in East Asians, the minute you have CHA2DS2-VASc score of 1 in any category, so this is males, you start off with a score of 0, you have 1 in any category, the hazard ratio is high enough to already recommend NOAC anticoagulation. What about females? Females, because of their gender, they start with a CHA2DS2-VASc score of 1, and with 1, any additional component over here would already render them sufficiently increased risk of stroke. The hazard ratio is high enough so as to recommend anticoagulation. In addition, in Asians, I would like to point out that East Asians have a larger margin of safety with NOACs compared to Caucasians. So this is apixaban versus warfarin, and you can see amongst East Asians, the difference in bleeding risk is significant compared to the non-East Asians. And again, this is a larger study published in 2018, which showed that stroke, better to use NOACs compared to warfarin. Mortality, NOACs are lower compared to warfarin. Intracranial bleed, GI bleed, major bleeding, everything NOACs favors NOACs over warfarin. And for female gender, we find that female gender is a risk modifier. In other words, at very low CHA2DS2-VASc scores, it actually is not very important, especially if you are trying to start a NOAC. If you're trying to start a NOAC, a CHA2DS2-VASc score of 1 for males or 2 for females, gender is not very critical. But if you remove gender, it does affect the ability of this model, the CHA2DS2-VASc model, to predict stroke. And therefore, actually, the ESC didn't remove gender from their stroke the CHA2DS2-VASc scoring system. So therefore, a more simplified version of the ESC flowchart would be like this. So same as the first part, but to identify the true low stroke risk patients, use the CHA2DS2-VASc score. I think this is reasonable. If it's 0, then no antithrombotics needed. If it is not 0, then begin a NOAC. So I think that this, and only those who are not eligible or not suitable for NOAC, then consider warfarin. Okay, the other thing to come out from recent studies is the need to reassess stroke risk factors regularly. So this study shows that at the end of 2 years, for example, people who start out without any CHA2DS2-VASc risk factors, 15% of them would have hypertension, for example, and about 8% of them will have congestive heart failure, and the number just increases over time. So this is another paper also from the same group. At 1 year, about 16% of people who previously would not be eligible for anticoagulation would become eligible for anticoagulation. So it is important to at least do an annual reassessment of stroke risk factors. And avoid off-label NOAC dosing, because when you either overdose the patient on NOACs, or if you underdose the patient on NOACs, if you overdose, of course, major bleeding is higher. If you underdose, you can see that the systemic embolism and stroke rates are higher. So avoid over or underdosing NOAC patients. Follow the standard doses. What about antiplatelets? I think this one has been mentioned before, but it's good to reinforce. Antiplatelets therapy alone is not recommended for stroke prevention in AF. It's actually a class 3 and level A evidence recommendation. How do we explain this when previously we were using aspirin or clopidogrel? Well, antiplatelets do reduce stroke rates. For example, somebody with a lacunar infarct before, giving clopidogrel does reduce future risk of stroke, but not for cardioembolic strokes. So therefore, in the setting of AF, where the intent is to prevent cardioembolic stroke, antiplatelets do not work. They only increase the bleeding risk without protecting somebody from cardioembolic stroke. To prevent cardioembolic stroke, we do need to use either warfarin or NOACs, and NOACs are preferred. I'll touch briefly on this appendage occlusion devices. We have now 3 in the Western market. There's this Emplaza or Amulet, there's the Lariat, and there's the most established Watchman. And I think over the years, we can see that the success rates, at least for Watchman, has been going up, and the complication rates have been coming down. And for the Emplaza, now the amulet, the success rates have been fairly good, but the complication rates have been coming down. So therefore, although it is still a 2B recommendation, and that's because in the recent guidelines, because until recently, Protect AF and Prevail were the only RCTs comparing Watchman with warfarin. Newer RCTs have been reported and are being and will be reported in the near future. An example is the PRUG 17 RCT, which randomized about 400 over patients to either a amulet or Watchman versus DOAC or NOAC. And it found that actually between the two groups, the left atrial appendage occlusion device group was non-inferior statistically to the NOAC. So therefore, in summary, for stroke prevention of AF in 2020, I think that over the recent years, multiple additional stroke risk factors have been identified and developed further. Despite this, the CHARTS-VAS score remains the most established utilized score to determine the need for anticoagulation. And NOACs are recommended instead of warfarin for most of our patients. I think that there will be an increasing role for left atrial appendage occlusion devices in the near future. Yeah, thank you.
Thank you, Daniel, for a very good summary on essential CHARTS-VAS and the risk factors associated with stroke prevention. Maybe just one quick question when we move on to the next speaker in the interest of time. There's a question on how do you look and how do you evaluate or how do you calculate the P-wave axis on a 12-lead ECG?
Yeah. So I think that's interesting. So basically, you have one way, of course, would be to look at the automated 12-lead ECG. So most of the automated software, for example, on Philips, would have this ability. You can look at P and you can see the axis over there. But it's also possible to calculate it manually by looking at all the different leads and doing sort of a vector sum of it. Yeah, but a simple way would be just to look at the automated software really. Yeah, to be quick. Thanks.
All right, thank you. There were some questions addressed to you, Daniel, earlier on. For example, what are your thoughts on device-detected atrial fibrillation and when you start anticoagulation? That's one. Number two would be, if AFib was found to be secondary to an acute illness, sepsis, do you still anticoagulate and for how long, even though he's gone back to normal rhythm?
Yeah. Okay. I mean, I didn't have a lot of time to cover the whole spectrum of this. So just allow me to share a few more slides. Actually, I have like probably a lot more slides, but just to show this. So I think that, you know, for device-detected atrial fibrillation, we have to look at several things. We have to look at the burden, whether it's how short is it? Is it like less than 6 minutes? Is it like between 1 hour or to 24 hours, or is it more than 24 hours? The greater the burden, the higher the likelihood of having a stroke. But at the same time, we also have to sort of look at the risk of getting a stroke as well from the CHARTS-VAS scoring system. And again, you know, so if somebody has a very high burden, device-detected burden, and a higher CHARTS-VAS score, then I think that anticoagulation would be recommended. So this is a quite interesting table also from the ESC guidelines of this year. And it shows that the ones really in red, or the ones in red, these are the patients that would have sort of exceeded the 1% per year stroke risk, in which we would then recommend a NOAC. So somebody with a CHARTS-VAS score of maybe 3 to 4, for example, and an AF of between 6 minutes to 23.5 hours, based on the ESC guidelines, they would have exceeded a stroke risk of 1% per year. And therefore, in this particular patient, I would suggest a NOAC. Whereas somebody who may be a CHARTS-VAS score of 2, but the same duration or same burden of AF, then maybe wouldn't require anticoagulation. So I think this table is helpful, but this is sort of based on our best studies so far. I think there are about 2 or 3 studies, randomized controlled trials that are ongoing that will help to further clarify this area. But this is the best that we have at this point in time. Sorry, what's the second question?
In patients with atrial fibrillation due to acute illness, for example, sepsis, and has gone back to normal rhythm, what are your recommendations for anticoagulation?
Yeah, I think that for patients with acute illness and acute sepsis, or even for post non-cardiac surgery, I think that the recommendations increasingly would be to anticoagulate, with the exception of maybe the rare case, maybe just a like thyroid storm, for example, which is not going to recur because of somebody is going to get radioiodine treatment, for example. But apart from that, in the patients in whom has sepsis and stroke, there have been studies to show that in this group of patients, they actually have an elevated risk of stroke several years out. That means 1 year later, 2 years later, 5 years later. Patients who had provoked AF due to sepsis, due to non-cardiac surgery, they have higher levels of stroke later on. So therefore, I would still go by the Charts-VAS score and would anticoagulate them. So the exceptions would be like what I mentioned, the thyrotoxic patient going to be treated, or maybe the cardiac surgery patient. So I think in cardiac surgery, post-cardiac surgery, I think the recommendation for anticoagulation has dropped to a 2B. But other than that, I would recommend anticoagulation for most of these patients. Thank you.
Thank you.